All right, so to keep us on time here, welcome everyone. My name is John Patania. I am the program director for the Brown Lifespan Center for Digital Health. For folks that are kind of first joining us today, just to kind of set the stage a little bit, the Center for Digital Health, we are a collaboration between Brown University and Lifespan Healthcare Systems, which is the largest hospital system based in Rhode Island. And our goal here is to facilitate the development and dissemination of effective and equitable digital health tools that make a difference in the health of patients and populations. We have a number of strategic areas, one of them being to create community and another to educate and build up the digital health workforce. And as part of this educational initiative, we host these regular seminars that happen about once or twice a month to both expand our skill set and our sense of what's possible to create or potentiate new collaborations between folks who are really passionate about digital health. I'm really excited to welcome our presenter, Dr. Andrea Graham, today, who is joining us from Northwestern University Center for Behavioral Intervention Technologies, based out of Northwestern's Feinberg School of Medicine. Her program focuses on the design, optimization, and implementation of evidence-based digital mental health and behavioral interventions. Dr. Graham, it's such an honor to welcome you to the CDH. I will now hand it over to you.
Thank you. And thank you so much for this opportunity to be here. Let me make sure you see the correct slides or slide view.
Yes, we do. Thank you.
Good. Okay, good. This is such an honor, and thank you all for joining. And I'm thrilled to be able to be part of the presentation kickoff today, the series. As John mentioned, I'm going to be presenting on designing digital health interventions and their implementation into practice. One of the things he and I had spoken about just before everyone joined is the goal is to both be a bit didactic in sort of what is human-centered design and some examples of that work, and then also share a little bit about my own research in this area. So please pop questions in the chat, or I don't know if the hand raising feature comes up. So please feel free to ask questions as we go through. If I miss it, John will jump in. So I really appreciate that. And as he kindly shared, I'm here at Northwestern in the Feinberg School of Medicine. I'm a faculty in the Center for Behavioral Intervention Technologies, or CBITS, but I also have an affiliation with the Center for Human-Computer Interaction and Design. And I'm thrilled to share I'm also a fellow of the Implementation Research Institute. Let's make sure I can advance the slides. Okay, good. So as we all know who are interested in the seminar today, the disruptive innovation of digital interventions is the ability to extend treatment beyond in-person sessions into the fabric of people's lives. And sort of my key premise of the talk today is if these tools are not engaging, people will stop using them. And so the implication is that they have to be engaging in order to have clinical impact, quite simply. But we know that engagement's a problem. So when digital interventions have moved from research settings to real-world settings, implementation has frequently failed, where we see low rates of use and retention among patients and failed integration within their systems of care. And why is that a gap that we're seeing? Well, basically, interventions have typically not been designed for the users and the context in which they will be implemented. And so the disconnect is that we need these digital tools to fit into the fabric of people's lives. So we need contextually relevant care that's better matched to patients' needs through personalization and more precision. And we need these tools to be better matched to clinicians' workflows through pragmatic approaches. And this is where design can help. So the goal of today is to talk about designing interventions to both meet users' needs and to integrate into workflows. And I'm going to particularly focus on healthcare, but this would be relevant and could generalize to other settings as well. So let's start with this idea of designing to meet people's needs and thinking about the role of mental health apps. So we can't simply translate a face-to-face treatment to a digital format, although many of us have tried to do it and unfortunately found that we've had a lot poor engagement when we do it that way. And why? So typically digital mental health interventions have been designed where they rely heavily on psychoeducation, so lots of reading over time, where they require 30 to 45 minutes of use per week, typically for 6 or more weeks. And in these contexts, engagement has been challenging. But now let's think about how people use apps. So for those of you that are in Chicago or have familiarity with Chicago, this is my route from work to home and back again. And here I'm in the office today as we all hopefully are in these funky hybrid transitions back. And so what happens is I open up Google Maps each morning and I decide, am I going to take the highway or Lakeshore Drive, and the latter being much prettier for those who have been here. And I see which one's going to be faster, and then I close the app. And at the end of the day, when I get to the parking lot at work, I then open up Google Maps, figure out which one to take home, and close the app. And so quite simply, we use apps in a single purpose for short bursts of time, sometimes frequently throughout the day, where our goals are much more often action over psychoeducation and reading. And in fact, for those of us on any sort of news app, Twitter, CNN apps, whatever it would be, it's very brief amounts of text that we're getting in any single instance. And what this is all trying to convey is that the user experience matters. And so this is a model colleagues and I put forth to show the way in which actually design and engagement metrics can actually be a mechanism by which digital mental or digital health tools can achieve changes in clinical outcomes. And our paper was actually to advocate for those that are familiar with the National Institutes of Mental Health for their RDoC criteria and experimental therapeutics to be expanded to include engagement as one of those metrics. And so essentially our concept is that well-designed interventions need to focus on both what we called subjective and objective use metrics in order to achieve changes in clinical outcomes. So objective metrics, and other people have used different terms, but this is what we used here, are really the sort of typical use. How often are you using the tool? How often are you engaging with the health system or manager of that tool? But perhaps more importantly, and I really do believe, is the subjective experience, that we actually need to design these tools to be useful to users, to be usable, something that they can actually navigate through with ease and remember how to go through it and learn how to use it, and create a satisfying user experience. And all of that is the one mechanism by which we could achieve changes in clinical outcomes, because our most potent tools can have no impact if nobody uses them. And this is where I mentioned human-centered design, or sometimes referred to as user-centered design or design thinking. I'll typically refer to it as human-centered design, or HCD today. This is where this approach can help. And so this is one model of the human-centered design sort of approach. Typically is like a process of methods that can be applied to different stages of the design process. And so at the top of the model is the investigate phase. It's purposely at the top. It is the start of all of this, and it is incredibly imperative. And basically, the goal of the investigate phase is to really deeply understand the goals, needs, and preferences of our target users and relevant partners and stakeholders who may be both using or impacted by this tool. So, for example, if you're designing for adolescents, you might be designing a tool that adolescents would use, but you also need to consider the relevant stakeholders. For example, maybe a sibling or a parent who might provide, gatekeeping access to that tool, for example. From there, we move into ideate, which is the section where we're generating. Once we've learned all we can about the population, we're then going to generate concepts and ideas for a product design. And, in a brainstorming phase, ideate phase, sort of anything goes, and we then move into prototyping. And I'm known to share in talks like, this one's my favorite section, or this one's my favorite phase. Prototyping I love, because really it's meant to be creative and iterative options for a product design. And essentially part of why I love prototyping is anything can be a prototype. So Post-it notes on a wall can be a prototype for maybe the layout of a screen. There's an awesome paper from even, I think at this point, 20 years ago, where they used a pizza box to prototype a briefcase. So really anything can be a prototype depending on how it is that you're using it. And then you move to the evaluate phase, where you're iteratively testing those prototypes with the relevant users who would use or be impacted by it. Now, it's a single arrow here. I don't know if you can see my mouse move. It is a single arrow between prototype and evaluate, but in fact, in practice, ideally that is an internal cycle that's happening over and over again, and sometimes maybe even moving back to ideate, where you're then creating different options over time and continuing to refine it until you're sort of ready with what you think your product design is going to be. And that's when you move to the refine and develop phase. And that's really where we're optimizing the design and actually developing the product. So it's literally not till stage 5 that we're even then siphoning the software development funds to then start developing the tool. Now, that's not to suggest you're not engaging with software developers earlier to think about the scope of the prototypes you're designing, but the development component doesn't happen all the way till here. And that's been really imperative. And I'm going to give examples of that in my talk. And then finally, this is where many of us who are clinical researchers are most comfortable or used to, which is the final, quote unquote, final phase or validate, where you're then testing the product design in practice. So possibly for efficacy, for engagement, this could be in a few weeks or in a clinical trial. But we also know that, I said final in quotes, because we know that anytime we put technology in front of people, we're going to learn new things and we're going to need to keep going. And so typically then this process actually would continue again. Maybe it needs to go back to the investigate phase. Maybe you jump down to new prototyping, but essentially this often, once we roll things out, we learn a whole lot more and we continue to build from there. And one of the concepts I'm going to talk about is the validate phase is really trying to start with what we call minimally viable products, or MVPs, so that we're really in this process of learning as we go throughout the process of design. Any questions on this? I know in a large Zoom, that's hard to open the floor for questions, but I'll just take a pause. All right. So why human-centered design? Well, importantly, there's actually great advantage to upfront efforts. So one of this is that it actually enables rapid learning. And so there's numerous design methods, most of which can actually be implemented relatively quickly. And so I direct your attention to a review paper at the bottom of this screen. This is just one example, but this was a paper I wrote a couple of years ago that actually presents some of the different methods that can be linked to some of the phases of design and sort of demonstrates how to go about the design process. It says for eating disorders, but that's the relevant sort of example based on my own line of work. But and then there's other books and tools and great websites that also provide excellent examples of these methods. But essentially, it enables rapid learning, and that we could implement these typically quite quickly. And in doing so, we're saving money and rework. So as I mentioned, it's not really till these later stages that we even begin software development. And that's really important because many problems from a technological perspective are avoidable if we give them adequate attention early on. And so if you then approach typically the biggest part of your budget is going to be actually spending the money on software design. So if you have a better sense of what you want to build before you actually start building, that's going to be much better. And I'll share an example shortly of sort of what we learned after building the tool in day one of rolling it out, like that we had to rebuild a whole lot, and that continuing to make sure that you're in a position to learn is really ideal.
Dr. Graham, we have a question actually.
Terrific.
What are some of the advantages and challenges of working with folks from other expertise, such as software engineers, in the prototype or ideate phase of the human-centered design process?
Big advantages, definitely thumbs up. Great question. I have sort of one of the things I've loved most about this is actually making sure that sort of to the extent that I can work with a diverse team of expertise. So there's actually a lot of advantages to working with the developers, not necessarily to come up with the ideas, but they also often have that expertise as well, but in part to also think about scope. So a great example that I'm about to share relative to my tool was to say, I want to create an eating log, right? Somewhere where people can track their food, and you'll see why that's relevant shortly. And then we thought, I don't have a lot of money to do that. And there's a lot of tools out there like a Fitbit that have spent billions of dollars doing it. So in talking with the software developer, we were able to come up with, okay, what's the simplest way to do it so that we can learn if people even like this tool, like this feature, are they going to even use it? And then we could get user feedback through qualitative interviews. And so it was really valuable to work with them then. So often now on my team, there's like sort of me with a clinical psychologist brain thinking about some of the clinical behavioral theory and that kind of approach, and sort of culminating the user feedback that I'm hearing. But then we also work with someone who is a designer by trade and the software engineer, and collectively we then try to think about like, how do we make this sort of a useful experience and putting it all together. So definitely thumbs up the more people you can have. It's not always the case that you can work that closely with your development team. Sometimes they say, present to me your software requirements document, and sort of that's it. And then you might go back and forth about what's relevant. But typically, in order to create your budget, you need to have a good sense of what you're going to build. And that's where doing all this upfront work can also really help. Or the budget, like my K award, dictates what you can build, and that also is relevant. So I'm going to now share a little bit about my Career Development Award, which really stemmed from, we've often seen the mind the gap from an implementation science perspective of, oh, we have this big gap between research to practice. My program of research has really been founded a lot on a clinical gap for people with both obesity and binge eating, where these individuals, we have interventions that work for weight management, we have interventions that work for binge eating, and we don't have an intervention that works for both populations. And so my premise has been that we need an intervention that's precise and can address both conditions, but also efficiently. So people have done wonderful clinical trials where they offer treatment for binge eating and then weight management, and then people drop out because it's going to take too long. So we have to be efficient. And then given the scope of this problem, we have to be scalable. And so this is not a presentation where you need to necessarily care about this particular topic, but it's designed to help you sort of use as an exemplar of how I applied the design principles to designing this this app. And so this is Food Steps. It's a mobile intervention for binge eating and weight management. And I show on the right-hand side the theoretical model that really grounded this work. That's important because often I hear when people say, oh, design, are you just going to do whatever people want? The answer is no. It's not just designing sort of willy-nilly whatever the user needs are. It's hearing the user needs and grounding them in clinical theory around how we create behavior change. But sort of the way in which we package that theory, so to speak, is really where user needs and goals and preferences can come in and be incredibly valuable. And sort of I share that the disruptive innovation of digital has been getting into the fabric of people's lives. The disruptive innovation of my career in the past few years has really been embracing human-centered design and recognizing that as a licensed clinical psychologist who's treated many patients over the years, right? Like what I think needs to go into this intervention is not necessarily how people engage with their phones and the kinds of tools that they want, and really sort of embracing that notion of engaging with the people who are actually going to use this tool. So I applied the various design methods across the intervention, and we did design activities with a large portion of people. I'll come back to this, and then subsequently ran a pilot trial. You'll notice that we've done design activities over the course of this this award with over 150 people, and my pilot trial is only 81. And before even starting the pilot trial, I think we'd had engaged over 75 people in design activities, meaning we spent a lot of time in these upfront efforts to really understand how do we design this tool to be most impactful for people's needs. And really, I started with this question around asking people, how do binge eating and weight impact your day-to-day life? And I love to share the humbling story that when I got my K award, hooray, thank you NIH, I was really sort of excited to just start building my tool. And the mentor from the human computer interaction space said to me, well, Andrea, you need to do a needs assessment. And I said, the investigate phase. And I said, well, no, like, I've been working with patients for a long time. I know what they need. And he said, no, you need to go back to the drawing board and start there. And that's why I really started with the initial question of how do these health problems impact your day-to-day life? And what I found, and just, that simple question, although we asked a lot more than that in sort of the way in which we did our study, is that people presented treatment with wide variation in past intervention experiences, interests, and needs. And this is sort of my duh slide, but it was really important at the time. And for many of these folks, behavior change in this domain was not new to them, where 100% had endorsed past attempts to lose weight, and over 90% had said they've tried to stop binge eating in the past. I don't know if they've done evidence-based programs or just doing things on their own. And in some ways, it doesn't matter. The point was actually that it reminded me I'm developing a tool that it's not being presented to people who are treatment naive or who are like sort of naive to this topic, and I need to sort of really think about ways to reflect that and sort of this wide variation in a single tool. And unlike in clinical practice, where you can have a conversation and work together in face-to-face treatments, in a digital tool that's asynchronously delivered, you only have sort of that one shot in a single session. So how do you then create a tool that allows for personalization and variability while still being in one tool? And this was my big challenge. So the other thing I did, which turns out I was sort of one of my favorite, I say favorite all the time, one of my favorite projects that I didn't even realize how important it would be, was then to prototype this idea of how do we think about user-directed behavior change. And I want to give a shout out to my colleague, Sean Munson at the University of Washington, and he's part of the design field and their Alacrity Center there. He really thinks a lot about user-directed behavior change and helped me think through this idea where we said, like, you know, what do you want to work on? And I gave people options within that theoretical model I presented early on. And I said, okay, now go do it for a week. And I gave no feedback. We just let people do it and report back to our team on their experiences throughout the week. And so what happened? The vast majority of people said that it went as planned or somewhat as planned, and just picking something and working on it on their own with no instructions. Did it help? The vast majority said yes. Would they keep it going? The vast majority said yes. And did it work? We didn't expect to see any changes in people's health, but we technically asked them at the before and after. And we saw average within subject reductions in weight and binge eating. And so what that really implied was that there's some benefit of offering choice in selecting skills to practice, and needing to be aware that we want to offer some customization where it's within still a defined array of credible options. So still creating swim lanes for people. And we need to also offer support in problem solving. So I mentioned I didn't give anyone feedback over the course of the week. And some people are saying it went somewhat as planned or didn't go as planned at all. Like, we can't just let people, I think what it also proved to me is it's not necessarily ideal to let people just go about this for an entire week without any support in doing this, that they need some support in that way. And that was incredibly powerful for the tool I designed. And then lastly, just as a fun design exercise, this is sort of I don't know about controversial. Not everyone likes personas in the design field. But one of the things I did just as a fun exercise, and we were able to publish this in a Frontier special issue actually, was create personas. And what personas does is think about the different kinds of character archetypes of individuals who could go through your technology, who might use it. And it helps you remember the different types of people who could be using it. So you're not just designing it for like one person, but that you're remembering the variability that can come about. And typically a persona is designed, where it's someone's name and it actually creates a character, like, oh, hi, I'm, Mary, and my age and a little bit of background. And I sort of flipped it on its head and thought about actually sort of eating challenges that people can experience and times that are high risk, sort of pain points, problem areas that might sort of be getting in the way of when they want to work on their eating behaviors or exercise behaviors. So I came up with 5. This is an example, and often a persona includes an image of like their likeness, so to speak. I did it as sort of archetypes of what that sort of challenge area. So someone who's a snacker, they're constantly eating and they're like sort of constantly sort of snacking and nibbling, but then not quite actually getting full or having real meals. That's going to be a problem for sustaining their eating habits over time. So anyway, this was just a fun exercise, and I like to show it as sort of unique in our space, I would say. So design to development. And so what does Food Steps include? It's quite simple, actually. Someone once phrased it, I designed a goal setting app, but basically it includes a weekly symptom assessment, very brief psychoeducation, goal setting and tracking, and then the eating log, as I mentioned. So when I mentioned psychoeducation, I mentioned at the start of the talk that I had done, we did what's called a field test where we had 4 people go through the intervention over the course of 4 weeks, and this was a way to just really make sure that like sort of the bugs and any glitches were getting worked out, that we could just sort of practice rolling it out before the big clinical trial. And I had much longer really nicely written up psychoeducation descriptions for people to read through. I spent all these hours drafting them up, and everyone said this day one, it's way too long. I don't want to read all this. And I had to chop it down to 3 app pages per section, per session, which is once a week. So for those of you who are used to giving psychoeducation, 3 pages on an app is like basically 3 paragraphs. So it was incredibly challenging, but truly, by and large, constantly I'm hearing feedback like, oh, it's just the right amount of reading. I loved the amount of reading. I learned so much. And that was really surprising and a great learning experience for me. And then the other piece that we have is really this idea of goal setting, where going back to my prototyping, we really allow people user-directed behavior change, where people are able to set a goal that they want within a defined array of options, and then they plan for that goal over the course of the week. And then a coach actually gives feedback over the course of the week so that they're not left, totally in the dark on how they're doing. And then lastly, they can mark their progress with a star rating. One thing I'm not going to spend too much time on, but one of the important things within design is actually iterating over time while still sticking to your key theoretical model. So a lot of us at CBITS, and me included, are of the mindset that rather than leave with an obsolete technology, by the end, we can continue to iterate and make changes as long as they fit within sort of the core concepts of what we're trying to do. And I realized that one of the features that I sort of thought people would continue to do with their weekly goals was to continue practicing the goals from prior weeks. And then I realized that we never actually designed a tool to help them do that. And so this was a feature that we added during the course of the trial, continue prior goals, which was a really sort of great addition, and actually driven by user feedback also, where they said, oh, I wish I could sort of pick old stuff too. And so we added that in. And so that's an example where we iterated over time. So how it's going, the trial's just wrapping up. This is some preliminary data from earlier on in the trial. So as a testament, I would say, to all of our design activities, the usage has been quite high, where users are completing 80% of the program on average. And relative to other digital tools, that's pretty awesome. So we're really proud of that. And compliance is high, or adherence. So basically targets are being selected and assessments are being completed on the vast majority of sessions that users actually complete, which is awesome. And sort of opposite of what most, I would say, clinical scientists tend to have, I think greater precision is needed. So we've seen average weekly reductions in weight and binge eating. Thumbs up, awesome. And I would argue we're still seeing suboptimal proportions with weekly improvements. So as I mentioned, unlike most people, typically we don't have good engagement, but we have a select few who are doing great in a program. We're having really good engagement and then having room to be more potent. And I love being in that position. I think it's a really good place to be in terms of what the next steps are. Excitingly, I'm having the chance to test these next steps, and I'll share a bit about where we're going now, which is that basically, in addition to needing some more precision, we then did a lot of qualitative work with the current users to understand what should come next. And we were actually hearing what I call design crossroads, for lack of a better term, where it's actually this interesting conundrum around. One question was, how do we sequence these targets, the different challenges people work on? How do we sequence that week to week? Should people work on the same thing or new? And the reason I call it a crossroads is qualitative feedback was literally conveying people wanted opposite of each other. So some people really said, I'm picking the same goal over and over again, but that's what I needed. And other people have said, maybe help people diversify if they're not doing it already. Or, if you did that one, you were going to limit the number of goals you have. And theoretically, those are actually 2 different concepts, where one is really the idea in behavior theory. If we continue to practice, we're going to facilitate learning. And then the other one would be measurement-based care, whereas if people are doing well up to a certain point, change it up. And if they're not doing well, think about the treatment plan, right? And so this is one way I conceptualize it. We're at a design crossroads for next steps. And then similarly, should we let people be completely free choice? Should we recommend things and actually help people sort of be a little bit more in that guided customization idea, or actually just assign it all together? And this was, again, driven by user feedback, where some people said, I really liked being able to make my own, and other people, or I wish you made a recommendation. And other people said, actually, free choice is problematic for me. I really wish you would tell me what to do. And both of those fit into behavioral economics, where you can have key theories to support either of those design ideas. So excitingly, we wrote a grant and we got it, which is awesome. And so my colleague here at Brown, actually, Steph Goldstein's on the call and is a collaborator and co-investigator on this trial as well. So this is now a micro-randomized trial to then learn specifically. We're going to, test these crossroads at its head, where we want to understand what evidence-based targets are most impactful for which people, when they should be delivered, so what sequence we should deliver it, and then how best do we deliver the targets to propel users to change their behavior, by either making recommendations or assignments. And we're doing this through a micro-randomized trial where people will be micro-randomized each week of the 16-week intervention. And the goal is that then we can build a just-in-time adaptive intervention that then personalized targets delivery to people's needs, so through more precision. There's also several areas for future optimization we're thinking about. I'm going to fast forward through this just in the interest of time, but thinking about social determinants of health and some of the work that colleagues and I have been doing around, for example, food insecurity, managing expectations for weight loss and addressing weight stigma, and thinking about how do we help people better monitor various metrics in the program. But here's my broader vision, right? So I started off by sharing that this is a clinical gap, that people with these health problems are not getting the clinical care that they need. And actually, so I also have a R03 award to then apply what we call service design methods, to then understand how do we implement these tools in 3 different settings where people with binge eating or obesity would present for care. So primary care, a most common place we all present for treatment, also to a lifestyle weight management program and an outpatient eating disorder program, where I'm partnering with these 3 different clinics to say, how could we actually implement this tool in your setting? If food steps was the best intervention of all time, like how could people actually get access to it through your clinical practice? And so what we're doing is, relative to that term service design, we're actually creating service blueprints that map the clinical workflow for delivering food steps in the 3 clinical settings. And we're then creating what I've phrased as implementation roadmaps, where we're trying to specify the implementation strategies and adaptations to the intervention and setting that are needed to actually support implementing those blueprints in those settings. And this is an example table that includes the types of domains that we're thinking about. So for example, would this go into the EHR so that people could refer to the program? We talked to a primary care doc last week who said, do not put this into my EHR. I do not need one more alert. And other people would say, we absolutely need it, right? So how do we think about for each clinical setting where this fits into the clinical practice and along the timeline of a patient showing up for care? Which really directs me to the second phase of this presentation around designing for implementation and the importance of integrating these digital interventions into workflows. So I'll take a pause and then we'll have time at the end for questions as well. But if anyone has any questions at the moment. All right. And I realize in a big Zoom meeting, it's a funny way to do questions, but so similar premise as the beginning, in terms of we have to have these tools be engaging and that they have to be used in order to create clinical impact. That's going to be the same message applied here relative to workflows. So we know in general, integrating new interventions into existing workflows is challenging, period, full stop. That's a hard thing to do in general. But this is actually especially true for digital tools because the delivery differs from in-person or face-to-face services by design, right? We purposely design our digital tools to look different than face-to-face. And so how do we then think about putting that into a workflow that tends to be face-to-face or in-person typically? And there's been a gap in knowing how, so the methods and techniques to implement digital interventions into healthcare settings. So some colleagues and I proposed a set of implementation strategies specifically for digital mental health tools in healthcare practices, where we thought about the different phases of implementation and then took known implementation strategies and tailored them as proposed strategies across these phases of implementation. And so you can find this reference here, but we're going to talk about some of the important these ones. Some of them are particularly really imperative, specific to the digital tool that we're going to highlight here. And you keep hearing me say the word workflow, and John Toros, a leader in digital mental health, published a review last year in World Psychiatry, where one of his comments was that workflow considerations remain among the least explored but most needed factors towards facilitating implementation. And that's really, it perfectly captured sort of the work we've been doing in this area. And so I'm going to start with an example known as IntelliCare, which is a digital mental health intervention for depression and anxiety. This is a tool that's been around for many years through CBITS, originated by David Moore through National Institutes of Mental Health funding. And now it's being sort of driven towards commercialization. And I'm part of this team where we're thinking about how do we actually commercialize this app in healthcare settings for depression and anxiety. So we had an SBIR award where it was a collaboration between the company, Northwestern University, and this first trial was with the University of Arkansas for Medical Sciences, where we were comparing IntelliCare to treatment as usual, evaluating this app platform for patients, and evaluating a mental health app with primary care patients for the first time. And excitingly, results were exactly as we would hope, really outstanding, where we had large effects from pre to post treatment for depression and anxiety, comparable to what we see for face-to-face. And then interestingly, even though this was more exploratory, it wasn't what we a priori set out to test, when the control group, the waitlist group, actually then got the app, their symptoms then subsequently went down, and you could see in the blue line to match those who got the mobile app, and then the people who had the app sustained their changes over time. So this was really, really exciting. And this is a busy slide, but basically the goal is to demonstrate very high engagement over the course of those 8 weeks of treatment. Again, this is an app that's very uniquely designed to really think about action over psychoeducation, to really be brief bursts of time and use. And so it's a well-designed app that is associated with very high engagement. So we were thrilled to see that sustained here when implemented in primary care versus in sort of typical research trials. But now I'm going to talk about the workflow integration and this idea of referral management. I shouldn't say but. And so what we did is we actually launched many referral strategies to try to get patients to this tool. So we did some that were direct to consumer, some that were through clinician referral, and then some that we categorize as other, or more than one. So other being like a presentation on the campus that a clinician gave to people in the community and in the clinical practices, so that we considered an other. So we tried lots of different strategies, and the one I want to spend some time on is the EHR alert and order. And so this is a very busy schematic that is not for you to read, but to see how busy it is, where we mapped out the workflow of building an alert and an order into the EHR, where basically patients get screened in the practice for depression and anxiety. If there's a positive result, the provider would get a best practice alert. They could then order IntelliCare, the digital mental health tool, and then they could join our clinical, or sort of be invited to our clinical trial. So I don't want to minimize, this still was a clinical trial with screening procedures, etc., but essentially that this was one way in which we were trying to think about, can we implement this into the workflow? And we spent a lot of time with a lot of people. So going back to that question about the diversity of the team, we had a service designer, clinicians, researchers, the head of informatics, and the person who oversees the EHR, all working together on this. And I then find that interoperability with an EHR can often be best laid plans go awry, where essentially what we found is that EHR alert or recommendation from the clinician, of the people who came into our trial, only 4% came in through that clinician referral pathway. And keep in mind, I told you all these people that we spent on this, we spent a lot of money on that workflow piece. We spent a lot of time thinking about it. We didn't spend a lot of time printing out photocopies of a flyer, right? And the vast majority of people came through the direct to consumer pathway. However, we also know, oh no, I thought this was the slide. I missed a slide, so I apologize. What we also know that's missing here is this yield from the 4%. It actually translated, though, if you were someone who talked to your doctor about it, the people who then subsequently entered the trial from the original expressed interest was highest in the clinician referral. So my key message here is that not to say that we don't need clinician referrals, that we actually need to think about how to optimize it to the workflow in order to make that happen. And in fact, we got feedback from the clinicians to say, I love this tool. It was helpful that patients would bring it up, when I got the alert, it wasn't well timed to my session. It became problematic to use that alert, but actually I was able to have a lot of good conversations with patients, partly based on direct to consumer strategies you guys used, in order to make sure that we could actually have a conversation about this, and it opened the door to talk about mental health in a way that we hadn't before. So that was very positive. So it's not to say to get rid of the clinician referral, but actually to think about how do we optimize that while also still considering direct to consumer approaches. And then I like to share, because here I told you this was the trial went really well. I think it's important that when we think about our work in digital mental health, I want to also share, we had a penetration rate of 13%. And this was actually higher than other published trials have done in primary care. And I would argue to everyone on this call, that's not good enough. And we actually over-enrolled our sample, which is often not common in NIH-funded studies. Like, we did a great, in my opinion, we did a really great job with enrollment, and we still had 13% penetration. And so when we think about these tools as being sort of this opportunity to increase access to care, we need to do better in how we think about sort of how are we getting access to the people who really need these components. And so I'm going to close on these kinds of messages to really talk about this idea of assisting with onboarding and going back to these implementation strategies, and how important it is to really think about sort of that referral process, that onboarding process to these tools. And so we have a follow-up SBIR where we're collaborating with a rural healthcare a healthcare system in rural South Carolina. It's the first time they're referring to a digital solution, not mental health, but just digital altogether. And what we're doing is, this is a sort of a caricature schematic of how much time we're spending thinking about sort of that referral process. And we've worked very closely with the leaders in these clinics and with the residents of the program, and really thinking about how do we get patients to these tools, and how do we assist them with that onboarding process so that they're most supported in downloading this app and having a good opening experience. So in conclusion, we do have effective digital health interventions, great, but they're not widely implemented in healthcare systems and beyond. And successful integration requires designing these services to meet the needs of users and align with their implementation context. And I want to remind everyone of the importance of applying these design strategies. As we think about that, we also really need to be mindful that we're actually designing these interventions for all. So for example, we need to be thinking about the ways in which our digital tools can that they have capacity to promote health equity, I believe, and they also have capacity to exacerbate barriers to health equity. And we're seeing that now from COVID and other ways. And we need to be really mindful of how we design these tools to make sure that we're then not continuing to exclude certain groups from access to care. And so, for example, in rural communities, some colleagues and I put forth a paper to advocate for how we can resolve key barriers to advancing mental health equity in rural communities. And similarly, colleagues and I put forward the paper around the role of design for adolescents who have healthcare transitions really ripe with sort of transition, whose healthcare is really ripe with transition, sort of from pediatric to primary care, from maybe specialty to ambulatory care, and how do we think about using these tools adequately to support transitions in their implementation so that they're maximally used. And all of that's to say, we need to really think about designing for context and from the start. So getting things in front of end users quickly, early on, and focus on building minimally viable products that allow us to learn from users and continue to build from there so that we can iterate, and really embrace the fact that real world research comes with real world challenges, and making time and space to actually allow for iteration with our tools and with our deployment plans, our implementation plans and strategies that really allow for us to be most contextually relevant. And with that, I'll close. If you want more design resources, please feel free to email me, but also our website. We have some resources as well as a syllabus and articles from a digital a design for digital health reading course that we put forth. And then center directors David Moore and Madhu Reddy, they have a P50 award. So we have consultation that we offer through our Alacrity Center. So happy to support that as well. Thank you.
Thank you so much. That was so interesting, and a lot of interesting questions have come through. So I'm happy to facilitate a discussion now. So the first question that we have from the audience here is, Let me see here. How do you envision using digital tools for those who lack access to smartphones? Are there web-based apps just as effective?
Yeah. Okay, so what I should have shared is Food Steps, in part driven by my budget, was actually built as a website that is what we call a mobile web responsive app. So my developer says I can call it an app, but that technically it's really a website. And the reason that's relevant is it's much cheaper to do that relative to build a website than it is to build a native app, because then you have to maintain them on Android and Apple, and it's just a lot of work. Turns out, though, as part of my rollout, to your question, John, although on behalf of the audience, that actually it's been really impactful, because some people have said that they've really appreciated being able to access it on different devices. So we had one individual who, and admittedly during my screening process, right, because I want to make sure that I ask people, do you have a smartphone? Do you have a text message plan to be able to support coaching? And then turns out once we started to roll out, one of the participants, for example, said, I can't afford all these text messages. And rather than saying like, but you screened positive, instead we then said, okay, let's switch to email and try it out. Like, I'm not in the business of trying to not take everyone's money. And so, and it was a good learning opportunity to see what if we did it that way. And so, on the whole, in terms of broad scale, I think to the extent that, for example, on a commercialization front, for example, to the extent that like large industry partners can do all of the above, so native apps plus websites is really ideal, so that the access to care component can really be sort of broadened. There are some challenges, I think, a lot about the role of coaching. I think there's human support is still needed with these tools. And so admittedly, if we only have a website, like could a person still get text messages on a phone or some kind of, there's aspects that would have to be designed appropriately to align with all of that, not just the technology, but also sort of its service delivery model. But I think to the extent that that's favorable. I'll also share, I'll just close by saying, I've purposely designed my trials that I don't give people phones. I think that sort of could be a fake way of testing it. I'd be happy to have a discussion otherwise, but it sort of feels to me personally problematic to give them a phone to see how it would work in this context and then not have that be sustainable for them long term. Perhaps, but I'm happy to think that through with other people as well.
And a really interesting point, and I'm I'm kind of reading the question behind the question here in terms of access. It's also around kind of technology literacy, health literacy. How do we kind of create interventions that are effective, but obviously equitable to different populations?
Exactly.
Well.
I realize I should have mentioned one more thing. The bigger piece, I think, is how to think about connectivity. So if you've designed an app, admittedly, many people have smartphones. The Pew data that says 96% of teens have a right? Not everyone actually owns their smartphone just themselves. A lot of people share that tool. I'm not going to minimize that. I actually think it's the data plan that's tricky. And so the ability to have consistent Wi-Fi and the ability to have consistent sort of data to support that. And so I think that's the bigger challenge that I put forward to people in this space around designing to make sure that sort of your tool can work in airplane mode, right? So if our idea is that it fits into the fabric of your life, then you want people to be able to use it in the moments they need it most. And if they don't have consistent connectivity, like how do we think about that and access to these tools so that they can use it whenever they need and don't necessarily have to rely on Wi-Fi? I'm not going to tell you I've solved that answer, but I do think that's an important design challenge that I challenge people to think about.
Agree, and I think several researchers and clinicians in the space, it's that discussion around the digital divide. So I feel like we can talk about this forever. There's so many questions, and I apologize that I don't think we'll get to all of them, but I'm really excited to see this kind of robust engagement with the audience. So our next question is, did your group have any issues with clinician buy-in when implementing into clinical settings? If so, what steps did your group take to increase that buy-in?
All of the above. So in the trial with depression and anxiety, feedback afterwards was, so this was primary care. This was depression and anxiety, the most common presenting mental health problem. And this was a setting that also did have integrated behavioral health. So not, where it's not without wait lists and tons of challenges, but I say that because some of the docs commented, oh, I didn't think it was my job to refer people to this tool. Not that they were against giving people mental health, but they actually really felt like that's the role of the behavioral healthcare provider, not me as the PCP, because we have that system in place. And then similarly in this new rural healthcare setting, it's not that we're getting resistance, it's just the amount of things on people's plates. Of course, that depression and anxiety turns out is not always coming up all the time. So there's aspects of that. And then in the newest project, with food steps or weight management, some of them are saying like, oh, I'd want this for the wait list, but not for like my active, or some want it for the active people and not for everyone. So I don't know that anyone has blatantly said, I don't want app. Actually, one person sort of said, I don't use apps, but they haven't blatantly said, I don't really want, like, I don't want access to care. It's more about sort of the like for whom and how within the practice. There are questions around, oh, is this just for the people with mild, right? And so some of the work that we've done, David Moore recently published a paper on IntelliCare that shows it really worked for people across the symptom spectrum, across multiple trials. Similarly, in food steps, that's one of the areas we're going to be exploring is like people with more and more binges. Is it, how well do they do? So those are important questions. I'm answering too long. I'll be more succinct.
No, it's, and I'll share with the audience. I will kind of copy all these questions and send it to Dr. Graham, and maybe we can send something kind of post-event here. It's really great to see a lot of engagement here. So another question popping up is, when talking about the design process for digital mental health, recognizing that personalization has benefits for end users, what is that balance of designing for personalizations versus a quote unquote one size fits all model?
Yeah, so that's been where I think, and I need to sort of now write up the paper of food steps. I am just really sort of proud of its design as being quite personalized, yet still within the set of swim lanes that I needed within my trial design and sort of what I conceptualized. Meaning, I think that there is ways to do that. We absolutely have to do personalization with these tools, but I think it's actually, to me, the design piece that makes it really fascinating around the how do we get there? And then sort of methodologically, the new R01, by being a micro-randomized trial, is going to actually allow us to pull some of that out from a research perspective by looking at moderators at baseline, and I put baseline in quotes because it's on a weekly basis for the randomization, but to understand like, how do we then personalize based on different symptom profiles? So if you had multiple weeks of binges in a row and you're going up, which would be the opposite of direction we would want, you might need a certain kind of approach, like a recommended one or a particular target, relative to if you're actively going down, you might benefit from a different component. And again, as you can hear how much I drive a lot of my decisions based on user feedback, people actually had said to me, I wish you asked me more than just what was my weight and binges, but like, what was my mood and what's my motivation? And those are additional moderators we're adding in for people to fill out each week, so that we can better understand how we can cater to people's particular symptom profile. I think I'll just close with one more sentiment to the person's question. I think the beauty of digital is that you could deliver personalization with incredibly high fidelity, because whatever you build, minus any bugs, whatever you build gets delivered. It's how do you think about tailoring that based on, sort of clinical data points, I would say. Yeah.
Really, it's in my mind, that's like one of the kind of $1 million question, right? In digital mental health research. And I think in our last kind of last 4 to 5 minutes here, we'll finish this. We'll close out with this one question. And then I did save the questions from the chat, and I'll send it to you, Dr. Graham. But so for another $1 million question, I think from our colleagues here at Brown,
the funding
in thinking about digital health tools and in terms of sustainability, funding, supporting them, can you reflect around the pros and cons of different funding models that you may be considering for your apps, e.g. consumer purchases for themselves, health system purchases, etc. And I'll finish this question with, part of the role of the Center for Digital Health is bridging the divide between academia, the healthcare system, and industry, knowing that our three different sectors, I think, have really good intentions of creating these interventions and services for the greater good, but come with such different business models and different kind of perceptions of return on investment.
Yeah.
Can you speak a little bit to how do we bridge that gap? And based on your work, and yeah, I think that's a good way to end the presentation.
Sarah, it's the perfect billion dollar question, literally, actually, in terms of how much venture funding is going into digital mental health. And I don't know that we've nearly come close to solving it, but some colleague and I just put out a commentary last week that got published in the Eating Disorder Journal, basically speaking to this point, which is that academics are not incentivized in many ways to be able to fund and sustain these tools. And sort of what it leads to is sort of all this lack of progress, right? So we do all this work in our research settings, and then we just can't keep it going. And that sort of is the opposite of what we're all funded to do by National Institute of Health or other, mechanisms. Is really our ultimate inherent goal is to benefit the public good. So one of the things that we advocate in this commentary is really the role of partnerships. And our team's been pretty successful in partnering both with industry or with like nonprofits to think about like an implementation plan that could be sustainable within that setting. So designing the intervention or its delivery approach, like literally with that group to say, like, what could you sustain and what really can you not sustain? And how do we then make appropriate theoretical judgments around what we then build and test, and really doing sort of like a hybrid trial, but really then thinking about designing for context and testing it in those settings. So that's one approach of really then being able to partner, I think, collaboratively. From an academic perspective, I'd like to advocate that we also, sort of push our academic models to then not just only care about the next sort of clinical trial and funding, but that we actually continue to do this, that's sort of a lofty goal, but that like sort of the impact that we are having, make it count based on our promotion metrics for promotion and tenure, but that's more of a lofty goal. So I really do think the partnership model has been ideal as sort of developing these tools in the settings and with the implementation groups that could sustain it. So I've been trying to think more about how do we do that, and actually have a grant under review to do it. Like if funded, it would be amazing. Like thinking about a training institute that helps academics better partner with industry and understand business principles. And then Sarah, you would know this, but for those on the call, Enola Proctor, a leader in implementation science, put out a paper at the end of 2021, thinking about the role of market viability and the importance that we as implementation scientists and clinical researchers think about sort of understanding entrepreneurial principles and when we think about our tools. So the other approach is not just needing to partner with industry that might not fit for everyone, but actually, or nonprofits or groups that could sustain these tools, but also to then be mindful of when we're building it, like what would be the business model for its delivery? Who would do the coaching, for example? Where could this be sustained? Is it a direct to consumer, B2C, business to consumer, or is it a B2B where we're selling it to like where would this go? And then making sure our trials really reflect those approaches. Yeah.
Thank you so much for that. I think there's such rich, not only information, but kind of, I feel like we can talk about this forever, but one of the many things I love about our seminar series. So with that, thank you so much, Dr. Graham. With that, we will close out this particular seminar. Thank you so much, Dr. Graham, from Northwestern Center for Behavioral Intervention Technologies, CBITS. It's been a pleasure. Everyone, please look into the chat if you want to sign up for our listserv or to attend our next seminar series, which will be on October 19th. Thank you, everyone. Hope it is a good rest of the day.
Thank you.